then you have QRS, and then you have T wave, and there's no P wave, and there's a sudden QRS, which is even greater response than this one in amplitude, right? I mean, P wave, normal, P wave, normal, but then somewhere in the middle there's a ventricular depolarization without the signal from SA node. So that's called premature ventricular contraction. So you have premature atrial that will have a higher P wave than a T wave, and in premature contraction that will have a QRS complex without the P wave. Okay. If notice how this is also looking like a shorter PR interval, but it's not a PR interval, right? Because this is a T wave, not a P wave. So don't confuse this with WPW. Hereditary channelopathies, arrhythmia description, Brugada syndrome, and you have congenital long QT syndrome. Okay. So Brugada syndrome is autosomal dominant, most commonly due to loss of function mutations of sodium channels, pseudo-right bundle branch block, and ST segment elevations in leads V1 and V2. So that's going to be a transmural one, right? In V1 and V2, so that's sternal lead. So this is going to be your anterior septal, anteroseptal ones, right? So this is autosomal dominant, most commonly due to loss of function mutation of sodium channels, pseudo-right bundle branch block, and ST segment elevation in lead V1 and V2 on ECG. Treatment is prevent sudden cardiac death with intracardiac device. Okay. Yeah, the way I have it in my mind is like this looks like Bermuda, so Bermuda Triangle. It loses everything, and it's an ocean. Ocean is salty. So SA node, Na are sodium channels, right? Because ocean is salty, so sodium channels get lost in the Bermuda Triangle. That's how I remember it. For congenitally long QT syndrome, it's caused by mutation in KCNQ1, right? It starts with K. Okay, so the way I remember this one is, okay, I'll tell you how I remember this one. So first of all, let's look up puppies. You see 3 puppies, okay? One of them is Jarvel, one of them is Launch, and the other one is named, let's do these ones are cute. Right, Jarver, Launch, and Nielsen, okay? And see how their ears are down? So remember this photo, okay? And these are canines, right? So canines, so K. So loss of function mutation of potassium channels, this is important. Loss of function mutation for potassium channel causes the congenital long QT syndrome, okay? Why puppies? Because they're cute. This is a cutie, this is a cutie, this is a cutie, okay? And they're canines. So QT syndrome, canine, loss of mutation for K channels, affects repolarization, and it includes, do this one, so Jarvel, Lange, and Nielsen syndrome, okay? Jarvel, Lange syndrome, Nielsen syndrome. So the ears are down, autosomal recessive. The ears are down, so that's sensory neural deafness. That's why I keep pointing to the ears, because this is the one that has sensory neural deafness. So they'll say in a question stem that a person has long QT syndrome, and there's a deafness in one of the ears or both the ears. Which channel from these would be mutated, or loss of function mutation happening in which channel? So it's the K channels, potassium channels, right? So it can be either of these 3 things that you need to connect to. Either the K channel or the QT, long QT syndrome, or that it's going to have If it's autosomal recessive, it's going to be sensory neural deafness. Again, last time, let's look at these puppies. They're so cute. They're cuties. Okay. The another one is like a, Romano, an Italian guy, and Ward, American guy. Not cuties, but for me, maybe for you. So Romano Ward syndrome, autosomal dominant, okay, but they're pure of heart, so pure cardiac phenotype. They don't have any deafness because their ears don't, drop like a puppy. So no deafness for that. So Romano Ward syndrome and Jarvis Lange Nielsen. That's Jarvis. That's Lange. That's Nielsen syndrome. Their ears are down. Sensory neural deafness. QT syndrome and K channels. Next, sixth sinus syndrome. This happens in older people. Okay. This is age-related degeneration of SA node. ECG can show bradycardia, sinus pauses, sinus arrest, and junctional escape beats. Okay. They might give you this, so you need to know what this ECG for this would look like. So QRS, that's the ST, okay. That's a P wave, but no QRS. P wave, no QRS, and then here's a slight P wave, maybe. There's a QRS, right? QRS, P wave QRS, P wave QRS, and then again, it differs with the increase in ST segment. So age-related degeneration of SA node. ECG shows bradycardia. This is the most important sign. If they give you that this person is like over, 70, 80 years old and has bradycardia, the first thing you should think of is this sixth sinus syndrome, because this is in older people who have SA nodes degenerating. Then you have sinus pauses, right? So there's a pause over there. Maybe sinus arrest, so maybe a whole complex doesn't take place. Or junctional escape beats, okay? A P wave is there, but then there's nothing after it. Cool. Myocardial infarction complications. So complication time frame, findings, and notes. Cardiac arrhythmia, first few days to several weeks. This is basically the complications we did up there. So that's what, now they're just, going into it. So cardiac arrhythmias, first few days to several weeks. Can be supraventricular arrhythmia, ventricular arrhythmias, or conduction block. This is due to myocardial death and scarring. Important cause of death before reaching to hospital and within the first 48 hours post-MI. So if a person comes to the hospital and then he dies due to MI, it's probably because of an arrhythmia, right, or a conduction block. It happens due to the due to the scarring. So this is cardiac arrhythmia. Okay, now we are doing peri-infarction pericarditis. This can happen between 1 to 3 days. Findings are pleuritic chest pain, pericardial friction rub, and ECG changes and or small pericardial effusion. So there's a question about this one. The question stems about a guy who has a chest pain, but then he feels better when he leans forward. Okay, that's pericardial friction rub. But then there's also this another guy who has chest pain and then he leans forward, but it still hurts. So what can it be? It's a muscle pain. It's due to chondritis. It could be because of rib pain or intercostal muscle pain or something like that. It's not because of the heart then. Okay. If they mention leaning forward, it's between these two. That's why. ECG changes and or small pericardial effusion. It's usually self-limited. Okay. Papillary muscle rupture. 2 to 7 days can result in acute mitral regurgitation. Again, papillary muscles support the valves, so acute mitral regurgitation. It can lead to cardiogenic shock and severe pulmonary edema. Uh, this is more common in the posteromedial than anterolateral. Uh, Papillary muscle rupture. Okay, as the posteromedial has a single artery blood supply, which is posterior descending artery, right? Because that's the inferior side, not the inferior, but like the one that's on the back, right? And it's only supplied by either one RCA or MCA, right? Depending on the dominance. Whereas anterolateral, although RCA is the most common one, whereas anterolateral has dual LAD and LCX, circumflex or anterior descending artery. Interventricular septal rupture, this is due to the macrophages, right? So it can happen between day 3 to 5, that's when macrophages show up after the neutrophils, which was after eosinophilic strip with the wavy fibers. Right? Symptoms can range from mild to severe with cardiogenic shock and pulmonary edema, macrophage mediated degeneration, ventricular septal defect causing a left to right shunt, increase in O2 saturation, and increase in pressure in right ventricle. You have ventricular pseudoaneurysm. This is due to the free wall rupture. Right after free wall rupture, actually, this is the last phase, I think, between week 1 and 2 is 3 to 14. So yeah, 3 to 14, second last phase, free wall rupture. That causes LV pseudoaneurysm. Okay, so pseudoaneurysm, 3 to 4 days. Maybe asymptomatic symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombus. Rupture can also create cardiac tamponade. So free wall rupture contained by adherent pericardium or scar tissue. Right, so that's that thing right there can happen. Oh yeah, that's the papillary muscles right there, and that's the damage, I guess. What was it? Papillary muscle rupture. Okay. So yeah, that's what it looks like, a tree, doesn't it? With branches and then like this whole thing. This is the valve. Okay, and here's the aneurysm from the free wall rupture. So what that just means is that this rupture caused the blood to leak into the outside of heart, but the last layer of the heart, it couldn't break through it, so now it's just filling up, and the last fiber or the layer of the heart is actually keeping it contained. But that's the aneurysm. So it does not contain endocardium or myocardium, right? It only contains the ectocardium, or I don't know what it's called, but the outer cardium of that, pericardium, I think, right? Then you have more likely to rupture than true aneurysm. Okay, ventricular free wall rupture can happen between days 5 and 14 as well. The free wall rupture, see this thing right here. Cardiac tamponade, acute form, usually leads to sudden death. Left ventricular hypertrophy and previous myocardial infarction protect against free wall rupture. Okay, so if there was a hypertrophy here, that can help protect against free wall rupture. Or even previous MI, because then there's scarring over there, which is keeping it, which is stronger, I guess. Then you have true ventricular aneurysm. This can happen anywhere from 2 weeks to several months. So similar to pseudoaneurysm, symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombus. Rupture will lead to cardiac tamponade, outward bulge with contraction, dyskinesia, associated with fibrosis. Post-cardiac injury symptoms of weeks to several months again. fibrinous pericarditis due to autoimmune reaction. This happens because of Dressler's, so also called Dressler syndrome. Cardiac antigens released after injury causes deposition of immune complex in the pericardium, which causes the inflammation. Okay, that's type 3 hypersensitivity as well, right? You have acute coronary syndrome treatments. So for unstable angina or non-ST segment elevation myocardial infarction, anticoagulations, for example heparin, antiplatelet therapy, for example aspirin, plus ADP receptor inhibitor, for example clopidogrel, beta blockers, ACE inhibitors, statins, symptom control with nitroglycerin with or without morphine. Then you have STEMI, ST elevation myocardial infarction. In addition to above reperfusion therapy, most important percutaneous coronary intervention preferred over fibrinolysis. If right ventricle affected, for example right coronary artery occlusion, support venous return preload to maintain cardiac output, for example IV fluids, or avoiding nitroglycerin. Okay. Okay, so again, unstable angina and NSTEMI. Right? This was the one with pain during rest, right? And this is the myocardial infarction because of subendothelial infarction, right? So that happens because of some kind of thrombus usually, right? So it could be blood thrombus or platelet thrombus. So you give heparin or you give aspirin, plus the ADP receptor inhibitors. These are clopidogrel. You can give beta blockers. Why? Because when you give beta blockers, what happens? There's decrease in heart rate and contractility, right? This causes decrease in what? The oxygen demand, right? So when you have decrease in oxygen demand, that's not gonna, that will help with decreasing the exacerbation because of that. Then you have ACE inhibitor, right? To decrease the blood volume. Hypertension. Statins to control the atherosclerotic plaque, in case that's also a reason, right? So symptoms control with nitroglycerin with or without morphine to decrease the blood volume again, and preload. Because if the preload is low, then what's going to happen? You won't need that much contraction. There's not going to be that much more, wall stress in addition to what it's already going through. So STEMI is in addition to above so you give all of this as well as you also do the reperfusion therapy, which is the most important because you don't want percutaneous coronary, you don't want, what do you not want? Dressler's or something like that happening over there. So percutaneous coronary intervention preferred over fibrinolysis, right? Also, you don't want the toxic buildup to spread throughout the whole heart, right? Through the coronary vessels. So you don't want that, basically. So what they're saying is it's better to do this one. This one, percutaneous coronary intervention that's going from, outside and then dealing with it mechanically, than dealing with it via drugs. Because basically, if you give fibrinolysis, what's going to happen? You have a thrombus between the artery, right? So fibrinolysis will break this up, right? But when you have broken this up, right, like that and like this can still travel to other places and like smaller vessels and then cause blockage in the smaller vessels, right? So that's why you don't prefer fibrinolysis. There, this vessel is blocked. right? So that's why you don't prefer fibrinolysis. That's why we prefer for going in and mechanically removing it. Okay. If right ventricle is affected, for example, the right coronary artery occlusion, support venous return, preload to maintain cardiac output. Okay, so you can give IV fluids and avoiding nitroglycerine. Okay, because you want fluid coming in and supporting that area in the right ventricle. Okay, cardiomyopathies, dilated cardiomyopathies. So these are the only two you need to know about, and I think that's all that's given anyways. Restrictive as well. Okay, but these two are the main ones. So dilated cardiomyopathies. This is the most common cardiomyopathy. 90% of the cases, often idiopathic or familial. For example, due to mutation of TTN gene encoding the sarcomeric protein Tintin. Right? Remember the cartoon Tintin? Adventures of Tintin. This guy, this cartoon. It doesn't help in any way to remember this. Just want to bring it up. Other etiologies include drugs, for example, alcohol, cocaine, and doxorubicin. Remember this one? Doxo and Don-rubicin, or Don something. They create free radicals because ruby is like a stone, and that resembles free radical kind of thing. So those two drugs and cocaine and alcohol can cause dilated cardiomyopathy. What else? Infection. For example, Coxsackie B, the hand-foot mouth disease, and also Chagas. Remember, Chagas make everything big. They make the esophagus big, they make the heart big, they make the colon big, right? So you have megaesophagus, you have mega colon, and dilated cardiomyopathy as well because of Chagas. You have big tongue as well in Chagas. Ischemia, for example, coronary artery disease. Systemic conditions, for example, hemochromatosis, sarcoidosis, thyrotoxicosis, and wet beriberi. This is peripartum cardiomyopathy as well. Okay, so all of these things can cause dilated cardiomyopathy. Findings: heart failure. You'll hear S3. S3 is because of what? The preload mixing in with the afterload. That's the sound it's going to make. And that the sound is designated as S3. Systolic regurgitant murmur, dilated heart on echocardiogram, balloon appearance on heart on chest x-ray. Okay. This is pretty easy. They'll just give you a specimen like this, and if you see it like that, you know it's dilated. But for that, you also should know what a normal heart dissection looks like. Okay, so that's what a normal heart looks like. Right, you can see how the chambers are small. The chambers are small here and here. And it's pretty tight, right? It's keeping the border pretty tight. See how the interventricular septum is right there, and look at its thickness, and look at the thickness of the left ventricle wall, right? There's a difference. You can make a difference because of that. So, okay. So, other etiology, we did that. Heart failures, S3, systolic regurgitant murmur, dilated heart on echocardiogram, balloon appearance on heart on chest x-ray. Treatment is sodium restriction, ACE inhibitor, ARBs, beta blockers, sacubitril, diuretics, mineralocorticoids, receptor blockers, for example, spironolactone, digoxin, ICD, and heart transplant. Dilated cardiomyopathy leads to systolic dysfunction. This is the cause of death usually, or cause of heart failure. Displays eccentric hypertrophy. So the sarcomeres are added in series. So that's just basically, this is sarcomere, that's a sarcomere, that's a sarcomere, that's a sarcomere, that's a sarcomere. That's, it's being added in series, okay? Over here, it's going to be added in parallel. So a sarcomere is going to be added here. So here, this is the muscle fiber, right? Like that. Over here, the muscle fiber is like this and like this, right? So another one is going to be added here, right under it. So this is going to get bigger. And then another one is going to be added in this, under here, in parallel, and it's going to get bigger. That's why you get a bigger, layer of the wall, like that, right? So that's why you have a thick wall over here. Okay, there's something called Takayatsubu or Takotsubu cardiomyopathy, so we'll learn about that as well. Okay, so displays eccentric hypertrophy, sarcomere added in series compared to athletes' hearts, where LV and RV enlargement facilitates increase in stroke volume and increase in cardiac output. Right, so this you can figure out if it's like, from the history as well. Stress cardiomyopathy, also called Takayatsubu cardiomyopathy. It's also known as the broken heart syndrome. This is usually the reason why you would hear like, okay, so there was a couple who've been married for like 80 years and then the wife died, and then 2 days later the husband died as well, or maybe even the same day. So it's because of broken heart syndrome. The ventricular apical ballooning, likely due to increase in sympathetic stimulation because of the stressful situation. So what will that cause? It will cause decrease or increase in firing. It will cause decrease in firing, right? So right here, so decrease in stretch receptor and decrease in baroreceptor firing will cause sympathetic response. So the heart will then give off sympathetic chain, and then it will cause the blood vessels to vasoconstrict, pushing the blood into the heart. But then after it's in the left ventricle, since there is increased total peripheral resistance, it's going to have to work a lot harder, right? But that causes dilation and eventually heart failure because ejection fraction is not preserved. Okay, so hypertrophic cardiomyopathy. Okay, 60 to 70% of cases are familial autosomal dominant, most commonly due to mutations in genes encoding sarcomeric proteins such as myosin binding protein C and beta myosin heavy chains. Causes syncope during exercise and may lead to sudden death in young athletes, for example, due to ventricular arrhythmia. This is important, and it's also important to know the difference between hypertrophic cardiomyopathy and between inherited cardiomyopathy. So the one with the inherited one, you'll see larger ventricular septum compared to the left ventricle wall. That will also have a hypertrophy, but you'll have hypertrophy more in size in the interventricular septum compared to this, right? Also, you'll have a smaller right ventricle compared to the one where it's only hypertrophy due to increase in blood volume. Okay. So, let's read this again. So cases are familial or inherited, right? Autosomal dominant, most commonly due to mutation in genes encoding sarcomeric proteins. This is a pathogenesis, or such as myosin binding protein C and beta myosin heavy chains. It causes syncope during exercise and may lead to sudden death. For example, in young athletes due to ventricular arrhythmia. So remember, myosin binding protein C and beta myosin heavy chains, mutations that make these. Findings is S4. This is because it makes the ventricular wall firm, that causes the sound. Systolic murmur may see mitral regurgitation due to impaired mitral valve closure. Treatment is cessation of high intensity athletics, use of beta blocker, or non-dihydrogen calcium channel blockers, for example, verapamil. ICD if high risk, avoid drugs that decrease preload, for example, diuretics, vasodilators. Diastolic dysfunction ensues, displays ventricular concentric hypertrophy, that's just this, sarcomeres added in parallel, so like that. Often septal predominance, myofibrillar disarray, and fibrosis. Classified as hypertrophic obstructive cardiomyopathy when left ventricular outflow tract is obstructed. Asymmetric septal hypertrophy and systolic anterior motion of mitral valve will lead to outflow obstruction, which will cause dyspnea and possibly syncope. Other causes of concentric left ventricular hypertrophy, chronic hypertension, and Friedreich's ataxia. So, yeah. Other than these causes right here, right? And young athletes. Restrictive. So if there's a young athlete that dies, it's usually because they had this hypertrophic cardiomyopathy. That's the reason. Restrictive infiltrative cardiomyopathy. Okay, so this is when they have fibrosis. So post-radiation fibrosis or Loeffler's endocarditis. That's the one with eosinophils. Rare restrictive cardiomyopathy caused by abnormal endomyocardial infiltration of eosinophils with subsequent tissue damage from degranulation, eventually leading to fibrosis. Okay. Endocardial fibroelastosis, thick fibroelastic tissue in endocardium of young children, amyloidosis, sarcoidosis, and hemochromatosis. So basically, the outside wall is going to, or even like the inside of the wall, between the layers, which would be infiltrative, gets fibrous, so there's no muscle to function like a heart, right? So that's called restrictive cardiomyopathy. Diastolic dysfunction ensues, can have low voltage ECG despite thick myocardium, especially in amyloidosis. So Loeffler endocarditis is right here. Okay, associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrates in myocardium. Cool. Now we're on to heart failure. This is the test you check. So heart failure, that's the test we do. Like I said, you press it for like 30 seconds and check to see if it makes a dentation. We don't do this test to determine heart failure. We just determine to see if it has if the patient has pedal edema or not. Right. So clinical syndromes of cardiac pump dysfunction. This leads to congestion and low perfusion. Symptoms include dyspnea, orthopnea, fatigue. Signs include S3 heart sounds, rales, jugular venous distension, JVD, and pitting edema. So that's the pitting edema, right? Why do we do this? Because this means there is some kind of congestion happening, right? Which is causing buildup of pressure in the vessels in the legs. So why legs? Because uh, that's the one that has to work the most to bring blood from the legs to the heart, right? So, and it doesn't have valves in the veins either to help it push it up, right? So what happens is, due to increase in the vessels, the interstitial hydrostatic pressure causes the leakage of fluid outwards, right? And that's the reason you get edema in the feet. Systolic dysfunction, heart failure with reduced ejection fraction, increase in end diastolic volume, and decreased contractility, often secondary to due to ischemia and or myocardial infarction or dilated myocardiopathy. Okay, so systolic dysfunction is heart failure with reduced ejection fraction, right? That just means that it's not pushing out the amount of blood that it normally does, so the cardiac output is decreased. So ejection fraction is reduced. Okay, normally it's around, like, let's see, how much is it? Like 65, I think. 55 to 65. Okay, so 50 to 75 is the normal ejection fraction range, right? So anything below that is going to be, not preserved, not considered preserved. So borderline ejection fraction can range between 41 to 50. So normally they'll give you like a value that's 25 or 30 or 35. Okay. Okay. So increase in EDV, that's end diastolic volume, the amount of volume right before systolic starts. Okay. And decrease in contractility will cause systolic dysfunction. Diastolic dysfunction is heart failure with preserved ejection fraction. Okay. And you have normal EDV. Okay. Because why? Okay. And because the systolic functions normally, so the ejection fraction is preserved there. So the cardiac output is normal because of that. There's decrease in compliance, right? That's what it is. That means the wall is stiff. So there's increase in end diastolic pressure. So instead of 80, you'll have like 110 or something. Often for diastolic blood pressure. Often secondary to myocardial hypertrophy. Okay. So right heart failure most often results from left heart failure. Okay. Why is that? Because say you have this heart here. This is left atrium, right atrium and right ventricle, right atrium and right ventricle. Okay. This is coming in from the lungs. This is going out to the aorta. Over there. This is going into the lungs. This is the SVC and IVC. Okay. So when you have left heart failure, what that means is that it's not able to pump out the blood as much as it used to, and it's not able to do that, right? So what's that going to lead to? It's going to lead to buildup of the blood, which will, cause backlog of more blood in left atrium, which will cause pulmonary congestion because of the backlog of blood into the lungs, and lungs will get congested. So you get pulmonary congestion. You can find heart failure cells there, and all this stuff, and dyspnea, orthopnea, all that stuff can happen because of this. What will this cause? Backup of blood here, and you can get Eisenmenger syndrome happening now because of increased pressure. So the right ventricle needs to work harder, so you can get all of these things happening there. What will this do? This will cause backup blood in here, right, into the right atrium, right? Then right atrium, if it pushes blood into the SVC as well, the backlog over there, or backup of blood over there, so that will cause superior vena cava syndrome, right? Increase in jugular venous pressure as well. You'll see that syndrome. Yeah. And if it goes down from IVC, it's gonna cause backup of blood in the hepatic or the liver, right? Now, liver is special because liver also has a portal vein, right? So portal vein, if that one also gets congested, what's gonna happen? Um, Portal vein has like 4 anastomosis, so wherever it has those sites are gonna feel the pressure as well, right? So that's why you get esophageal versus, because that's where the first one is. The second one is like in the around the umbilicus, so you'll see like umbilical veins forming the medusa, right? uh, you can get like perforated or hemorrhagic, uh, like you can puke out blood and because of this if your esophageal versus bleeds, right? Perforates or ruptures. Then like there are other two that we'll talk about in GIT. But because of that, there's also going to be you know backup of blood in the legs, and also there's all of this will increase the blood pressure. Increase in blood pressure is hypertension, and hypertension does what to the kidneys? It will cause the renal arteries to uh, basically form bigger muscles in the vessels. I don't know how to put it, but basically the blood flow is gonna get, the artery is gonna get bigger, but the area the blood flows through is gonna get smaller, right? So that's how you get the arterial stenosis, renal arterial stenosis, due to hypertension in heart failure. Okay, and then your kidney becomes ischemic, and then you have organ failure there. Okay, so that was a wrap up of that. Okay, so right heart failure often results in from left heart failure. Cor pulmonale, this is just a part of heart failure along with the pulmonary congestion. So it refers to the isolated right heart failure due to pulmonary causes, right? So for this, they'll say that the ejection fraction is normal. The left atrium has normal pressure as well, right? If they say normal pressure in left atrium, then it's not because of heart failure, okay? Because heart failure is the reason you would have increased blood pressure in left atrium. But if they tell you it's cor pulmonale, that means it's normal here. The pressure is normal. The PC, pulmonary wedge pressure or whatever, right? The wedge pressure is normal for LA. But you have increased pressure in right heart, so right ventricles, right? So right ventricle because of pulmonary causes. Okay, it could be anything. It could be edema, it could be embolism or whatever. Okay, so ACE inhibitors, ARBs, anything that decreases hypertension, right? So ACE inhibitor, ARBs, angiotensin receptor, neprilysin inhibitors, beta blockers, except in acute decompensated heart failure, because you need the heart to pump over there. And aldosterone receptor antagonists decrease mortality and heart failure, REF. So that's this one. Reduce ejection fraction, heart failure. So aldosterone receptor blockers, right? So ARBs. No, that's angiotensin. So aldosterone receptor blockers decrease mortality in heart failure with reduced ejection fraction. So remember this point right here. That's important. Loop and thiazide diuretics are used mainly for symptomatic relief. Hydralazine with nitrate therapy improves blood symptoms and mortality in select patients. Hydralazine is safe to give in pregnancy as well, I think. Okay, so there's a whole mnemonic for that that we'll see in the pharmac section of this chapter. Okay, so left heart failure. Because of left heart failure, again, this thing over here, you get orthopnea, shortness of breath with supine because there's increase in venous return from redistribution of blood. Immediate gravity effect exacerbates pulmonary vascular congestion. Okay, so increase in venous return from redistribution of blood. Immediate gravity effect. So, say you're sleeping, right? So your lungs are like this. Okay, when you're sleeping, it's just imagine you're sleeping and the whole body's over here. What happens to the blood supply here? Right, it's going all over. Right, it's going to distribute here, 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 and here equally. Okay, and if you have backup of blood over here, right, backup blood here, and because of congestion, what's going to happen to this areas? There's remember the arteries are being pushed inwards now because of the outside congestion, right? Because there's already fluid leaking through it because of the heart failure. Okay, so before when you were standing, your lungs were like this, and all the fluid that leaked from the capillaries was pulling down here. Okay, so you don't feel that dyspnea while you're sitting or standing, but as soon as you fall asleep, all this fluid is now going to roll around and throughout the lungs from here to here to here to here, and that's why you can't sleep, because you have difficulties breathing while you're sleeping. So that's why people prop up and put like 2 pillows in their head, under their head, and they sleep diagonally. So when they sleep diagonally, all the blood again pulls down here, so you have this much area that's capable of breathing. But when you're sleeping, all of the fluid is going to press every single artery there, right? So that's what shortness of breath when supine means. When you're sleeping, you have shortness of breath because there's increase in venous return from redistribution of blood. Immediate gravity effect exacerbates pulmonary vascular congestion. Paroxysmal nocturnal dyspnea, breathless awakening from sleep, increase in venous return from redistribution of blood, reabsorption of peripheral edema, etc. Okay. So when you sleep, what else happens? Your legs are now, laying down. So all of this now fluid that was here is now gonna seep back into the vessels, and then that's going to increase your venous return, right? So that's why the venous return from the redistribution of blood gets reabsorbed, and then that causes increase in venous blood volume in the right atrium, right ventricle, then the lungs, right? So the lungs is where you'll have increased congestion, basically. So breathless awakening from sleep, increase in venous return from redistribution of the blood. Oh, didn't realize that. Sorry about that. I didn't hear it. Okay. So shortness of breath when supine, increase in venous return from redistribution of blood. Immediate gravity effect exacerbates pulmonary vascular congestion. We did that, we did this. Breathless awakening from sleep, increased venous return from redistribution, reabsorption, and that. We did that. Okay, now we're on to pulmonary edema. Similar concept. Increase in pulmonary venous pressure. Right, venous pressure is this thing right here, that one coming into the left atrium. Right, so increase pulmonary venous pressure. Remember, the artery is the one going from the right ventricle into the lungs, and the venous one is the one coming into the left atrium. So increase in pulmonary venous pressure will cause pulmonary venous distension and transduction of the fluid. Okay, transduction is just going into the outside of the vessel, kind of thing. Uh, Presence of hemosiderin-laden macrophages. These are the heart failure cells. Okay, you should know what these look like, because don't confuse it with the lipofuscin, age-related pigmentation, right? So this is hemosiderin laden macrophages. They'll give you some kind of indication that it's, in the question, that it's some kind of a heart problem, because then you also gotta remember what is hypofusion. Remember, so that looks like this. Okay, so it looks similar to the heart failure cell, right? The hemosiderin. So that's lipofuscin, and yeah. So just figure out how to spot the difference between the two. Most of it, majority of the time, you'll figure it out from just the question itself. But yeah, pulmonary edema, if it's because of heart failure, you'll find these there. Okay, why? Because when this happens, there's breakage of, I don't know. Also, hemosiderin also causes pigmentation in the legs. And that will cause cellulitis kind of appearance, right? This causes depigmentation over here. Okay, so yeah, wherever it goes, it causes pigmentation. It's because of destroyed cells leaking out hemosiderin, and then that hemosiderin gets deposited wherever it can get, and majority of the time it's going to get deposited down here in the legs, and that's why you get pigmentation because of that. Okay, now we're dealing with the right heart failure, this part of the heart. So congestive hepatomegaly, increase in central venous pressure will cause increase in resistance to portal flow, right? We already talked about that. Because of this, it's gonna cause backup of blood in IVC, which will cause backup of blood in the liver, which will cause increased resistance to the portal flow. Rarely, also, okay, we'll talk about that in GIT. I don't want to add too much and overwhelm you guys. So, leads to cardiac cirrhosis, okay? Associated with nutmeg liver, mottled appearance on gross examination, or gross exam, okay? So, right heart failure can cause congestive hepatomegaly. It can cause jugular venous distension because of, again, if it goes up in SVC, right? Superior vena cava, because that gets tributaries of jugular veins, right? And the head and neck. Right? Peripheral edema is, why do you get peripheral edema? It's because of increase in venous pressure, which causes fluid transfusion. We talked about that already. Okay, so let's just look at this graph real quick. Decrease in cardiac output will cause what? Increases the sympathetic tone. When that increases, what happens? You get beta 1 and alpha 1 action. Okay, beta 1 action causes increase in heart rate and increase in contractility. Increase in contractility will cause increase in stroke volume. Increase in heart rate will maintain cardiac output. So will stroke volume, right? What's alpha 1 action? It's vasoconstriction, right? So you have vasoconstriction, increase in arterial tone and maintain blood pressure, increase in venous tone, increase in venous return to the heart, or preload. Okay. So vasoconstriction, increased arterial tone will maintain blood pressure and maintain the cardiac output. Eventually, this is what we want to do, right? And because this is what basically means if the ejection fraction is maintained or not. So that's what everything is about. Okay, so alpha 1 vasoconstriction, increase in venous tone. This will cause increase in venous return to heart, or also called the preload. Okay. Remember what preload was? It's the amount of blood that gets poured into the left ventricle. That's how we read it. But this is preload of the heart. That means the amount of blood poured into the heart. Okay. Increase in renin angiotensin aldosterone system, right? Because there's decrease in cardiac output. The brain's gonna think that there's not enough blood volume. So to increase the blood volume, it's gonna increase reabsorption of the water, right? So increase of water happens because of reabsorption of sodium, while it excretes potassium out. That's aldosterone's thing, and aldosterone causes a reabsorption of sodium and excretion of potassium. Okay. So through that system, and also angiotensin 2 is known to cause vasoconstriction. Okay, so don't forget about that. So via angiotensin 2, it's going to cause that. Antidiuretic hormone does exactly that. It prevents diuresis, right? So also it acts on V1 receptors as on the vessels, causing vasoconstriction as well. Okay, so these two, remember. So that will cause increase in venous tone. Increase in venous return will cause stroke volume to increase, which will maintain the cardiac output. On this side, you have angiotensin 2, aldosterone, and ADH acting in the renals, or V2, right, to reabsorb more water. These will absorb through the sodium, and this will absorb through the collecting tubule principal cells of the renal, and it will cause via aquaporins. That's what the word. Yeah, aquaporins. So it doesn't rely on sodium ions. This will just bring in the water without the sodium. These ones bring in the sodium. Okay. Increase in circulating volume, which will increase venous return to the heart, and stroke volume will then maintain cardiac output. If you don't understand this concept right now, you will once we do renal, which is I think next. So we'll figure it out then. Okay, but for now, just remember, if there's decrease in cardiac output, you get beta 1 alpha 1 action. Okay, and that's to preserve ejection fraction or maintain cardiac output. Okay, so what would that look like? This is the diagram that you will find when they're asking about it, and we did in physio, we did that in physio somewhere. Right there. Where'd it go? I think I skipped it. Somewhere here. That's weird. Where did it up there? Am I just going over it? I probably passed it like twice. Okay, there we go. So this thing right here, right? So if you remember this from yesterday, that's what we're talking about. Okay, so reduced ejection fraction is the systolic heart failure one, right? Systolic dysfunction. Where was that? Systolic heart. Wow, I'm so bad at navigating this. Okay, there you go. Systolic dysfunction, heart failure. Obviously, it's under heart failure. Okay, so that one was with reduced ejection fraction, and diastolic's the one with the preserved one, because the systolic works great. Okay, so what are you going to see when they give you a diagram like this? You got to figure out the contractility. So that's this thing right here, this line, right? And you can see compared to this line, this one is further away from this point, right? And that's how you figure out if the contractility is reduced. Okay, Uh, okay. And then the compliance is the same here, okay? So if you go like this and you make a like this graph right here, the compliance is on the same line, okay? So there is no difference in compliance with the systolic one, okay? However, in the preserved one, the compliance is reduced, right? It's gone up like that. You're not gonna get wait, reduced compliance is like that, I guess. Okay. Just remember this graph because I'm not able to explain it right now, but yeah, because this is weird. Okay, so I guess this line you can just think of it like that. If the distance between this and this is reduced compared to the black diagram, so that's from here to here, you can, I guess, say that the compliance is reduced because of that. So you can try it out like that. Okay, they didn't give us compliance here, so it's hard to figure out how that is. You'll figure it out in UWorld eventually. Okay, so pressure, so contractility is reduced in systolic, right? Because systole is basically ventricular contraction, so something's wrong with the contraction, so contractility is reduced. That's why you have reduced ejection fraction or the cardiac output. Okay, so the graph, the stroke volume is from here to here, right? So this distance is from here to here, and we can tell that it's similar. So the stroke volume is the same. It's just the contractility that's reduced. Okay, we put a line across like that. The afterload is increased a little, right? Obviously, the end diastolic volume from here to here is increased, right? Because this is like the middle part. This is end systolic volume. This is end diastolic volume. So end systolic and end diastolic both are increased in this, which is why the stroke volume is preserved. Right. However, the ejection fraction is still reduced. Okay. Over here we have similar stroke volume. However, the afterload is a little increased, but the end diastolic volume is almost the same as his end systolic volume. Just the compliance is reduced. Okay, that's preserved. Again, preserved is the diastolic one, and reduced is the systolic dysfunction. Okay. You'll be given a chart like this and told that this person has heart failure, and this is the chart that they got from the test, and then you have to figure out which one is it. Is this systolic or diastolic dysfunction? It's pretty easy to figure out, right? Just look at the compliance and you're good to go. Because here the compliance is the same, right? It's similar. This line and this line is the same distance between the two, so the compliance is there. However, the contractility is not. Okay, high output heart failure. So this is where you have, okay, uncommon form of heart failure characterized by increase in cardiac output. High output state is due to decrease SVR from like SVR, that's systemic vascular resistance, right? So decrease in systemic vascular resistance from either vasodilation or atriovenous shunting. Okay, AV shunting is, again, it's when the blood goes from atria to the veins without passing through the capillary network. Why? Because capillary network is the one that has increase in area cross section, right? So it reduces the pressure. However, here it's going to increase because it's going directly into the from one big vessel to another big vessel. Causes include severe obesity, advanced cirrhosis, severe anemia, hypothyroidism, wet beriberi. That's the one with the hypertension. Paget's disease of or Paget disease of bone presents with symptoms and signs of pulmonary and or systemic venous congestion. Okay, shock, inadequate organ perfusion or and delivery of nutrients necessary for normal tissue and cellular function. Initially may be okay. Initially may be reversible, but life-threatening if not properly not treated promptly. Okay, so there are four types of shock. You need to know this chart because it comes in many systems, right? So for hypovolemic, it can come in hemad, cardiac is this, obstructive, it can be lungs, and you can have distributive and like micro as well as neuro. So this is how you figure out what kind of shock it is. Okay, so hypovolemic shock caused by hemorrhage, right? It's leakage of fluid or volume of blood. Okay, so you have low blood or low volume of blood, so you go into shock because shock is inadequate organ perfusion and delivery of nutrients, right? So hemorrhage, dehydration, and burns. Mechanism is volume depletion. The skin, it's not gonna, it's gonna be cold and clammy actually, right? Then you have central venous pressure, right? So right heart preload. Preloads the amount of blood poured into the right heart, so right atrium, via SVC and IVC. That will decrease. Then you have left atrium, right? So if preload is decreased, obviously the blood coming from the lungs is going to be decreased because it receives blood from right heart, right? Then if there's low preload, then you have obviously low cardiac output. Okay. Now remember when we read in hypoxia, vasoconstriction happens in the lungs, but everywhere else there's vasodilation. However, in hypovolemic shock, don't confuse it. In the systemic vascular resistance, it increases. Why? Because since there's low blood, the brain tells what? In decreased cardiac output, what's going to happen? The brain's going to, sense it, and it's going to send out sympathetic signals, right? So sympathetic signals are going to do what to the vessel? It's going to vasoconstrict. So vasoconstriction is going to cause what to the systemic vascular resistance? It's going to increase it. Okay. Then we have SpO2. That is what? I think that's just okay. So mixed venous content. So how much oxygen is going to be in the veins, venous side? Because oxygen gets picked up from the arteries and then it goes into the vein, right? So you would imagine that since all the organs are being deprived of oxygen, as soon as it comes, it's going to pick it up. So by the time it reaches the veins, it's not going to have as much oxygen as it used to normally, right? So it's going to be decreased. Okay. Sorry. Cardiogenic shock, myocardial infarction. It's caused by myocardial infarction, heart failure, vascular dysfunction, or even arrhythmias. Mechanism, left heart dysfunction, right? That's the mechanism, because this horrible diagram I made, remember that. Okay. Then again, blood's not reaching organs, so it's going to be cold because it's not able to bring in the core heat into the other parts of the body. Okay. The right heart preload is going to be what? It's going to increase. Okay. This is central venous pressure. It's going to increase as well. You can just imagine, like, it's trying to pour into the heart, but the heart is already backed up, right, because of the left heart dysfunction. So left heart is going to cause backup of, oh god, I'm doing this again, backup of left atrium into the lungs, back up into the right ventricle, and then right atrium. So it's going to cause backup in this IVC and SVC, and if it's doing that, then it's going to do it to all over the place. So central venous pressure is going to be increased, right? That's how that is. Again, it's the left heart dysfunction, so pressure is going to increase in the left atrium as well. Cardiac output, however, since it's a left heart dysfunction, it's not able to perform its duty, right? So the cardiac output is going to be decreased. Systemic vascular resistance, again, it's being deprived of, like hypovolemic, so it's being deprived, right? Again, cardiac output is decreased. It's going to send signals to the brain. Brain's going to think we don't have enough blood in the vessels and stuff like that. So again, sympathetic response. Sympathetic response is going to cause what to the arteries. It's going to cause vasoconstriction, right? Again, same thing here. Mixed venous content. By the time blood gets to the veins, it won't have any amount of oxygen left. Okay. Now obstructive shock. These are your cardiac tamponades or pulmonary embolism or tension pneumothorax. Okay. This is a physical obstruction in the flow of the blood. Okay. That's what this is. So flow of the blood can be impeded by the embolism in the lungs, right? After it goes from the right ventricle before it comes into the left atrium. Or it can be because of cardiac tamponade. That's this thing right here, fluid in the heart layers. Didn't tell you that here, but pericardial space, I guess, right? So in the pericardial space there's fluid, so it's pressing into the chambers, and it's preventing preload and all that stuff, or it's affecting that. So, and then you have tension pneumothorax. Tension pneumothorax is again pressing onto the lungs, so it's being impeded. The blood flow is being impeded in the lungs. Okay. Mechanism is right heart dysfunction. Okay. So left ventricle and left atrium are not affected. They are going to have normal amount of pressure in them, but pressure is going to increase in the right ventricle and right atrium and central venous pressure, right? Because HVC, IVC, and all that. So that's going to increase. Left atrium, heart preload. What is this? Okay, it's increased in cardiac tamponade, but it's apparent. Okay, it's apparent because it's relative to a normal. It should be normal, but the pressure is not created by the blood. It's created by the outside border. Okay, what does that mean? I'll try it out. So you have right atrium over there. Sorry, left atrium over there, and you have left atrium here. Left ventricle here. Okay, and now this is the heart, right? So it goes like that. So now the cardiac tamponade is when you have blood in the layers of this, right? So when it's filled up like that, it's going to keep filling up and whatever, for whatever reason, and wherever it's coming from, it's probably coming from the aorta or something, right? The leakage is coming from there. This thing is going to build up. It's going to push this way, and it's going to push downwards as well, right? Into the thing. So when it's pushing downwards, this thing can, go into it and build up the pressure because of that. It's not that the blood is coming in and then pushing into the walls and creating the pressure. That's not what's happening. What's happening is it's the cardiac tamponade pushing it. So that's why it increases in cardiac tamponade. Otherwise, it's normal. Okay. And then you have cardiac output, which is going to be decreased because, again, normal pressure or lower. Right? So decrease in cardiac output. If you have decreased cardiac output, it goes to the brain. Brain signals sympathetic response, and then you get increase in vasoconstriction, causing SVR to increase. Okay, and again, they're being deprived because of decreased cardiac output. So mixed venous content is going to be decreased. Okay, all of these will cause skin to be cold and clammy. Okay, hopefully I was clear about those things, and you'll remember it now. Distributive shock, sepsis, and anaphylaxis. This causes what? Systemic vasodilation. Okay, Because remember, sepsis causes what? Increase in neutrophil. Neutrophils do what to the permeability? It increases and it causes vasodilation, right? So that vasodilation causes what? It causes warmth, right? Vasoconstriction causes cold, and vasodilation will do the opposite. So it causes warm and dry skin. Central venous pressure, what's happening to that? It's causing vasodilation, so obviously it's going to be reduced. In left heart, preload will be reduced because there's decrease in venous return because of vasodilation, right? Then you have cardiac output. Cardiac output is going to be increased because you have decrease in systemic vascular resistance, so there's no resistance whatsoever. So whatever the heart puts out is going to just gobble it up. And then you have in SVO2, it's increased. This is mixed venous content because it's vasodilated, it's getting enough oxygen, I guess. So that's the important one you gotta remember. This is the only one where it's increased. Okay. And then you have CNS injury. So now your sympathetic is not gonna work, right? So even when you have cardiac output decreased, you have decrease in SVR because you have CNS injury, so it's not functioning great. So systemic vasodilation, again, warm and dry. Your vasodilation, so decrease in venous return, so decrease in this CVP and decrease in left atrium. Cardiac output is decreased, so it should cause sympathetic response in the brain, but brain is not at work today, so decrease in SVR. And mixed venous content, so normal or increased because it's still vasodilated, so it could be increased or it could be normal. Okay, cardiac tamponade. So what is cardiac tamponade, right? So you see it right ventricle here, and then you see left ventricle here, and you see this space right here, the pericardial space is filled with fluid. Okay, because this is the outer layer of the heart. So between the outer layer and the inner layer, there's this pericardial space which is filled with fluid. So compression of the heart by fluid, for example, blood or effusion, which causes decrease in cardiac output. Equilibration of diastolic pressure in all four chambers, finding is Beck triad. Hypotension, distended neck veins, distant heart sounds. Increase in heart rate, pulses, paradoxes. ECG shows low voltage QRS and electrical alterons. This is important because with this you can just figure out what it's cardiac tamponade, but also because they might not give you the ECG, but they just tell you that there's electrical alterns, or they can, something like that. So why does this happen? It's because of this fluid. When the heart beats, you can imagine there's like a wave happening into it, right? So the wave is going to push into the wall and all that. So it's going to cause a swinging movement. So due to swinging movement of the heart in large effusion. Okay. Echocardiogram shows pericardial effusion. Like that. Systolic right atrial collapse. So when basically what that means is when this is pushing, left ventricle is pushing or contracting, it's gonna push the pericardial space as well, and this pericardial space then goes into the other side and onto the part where there's right ventricle, and basically the right ventricle is going to collapse because of the pressure of this fluid being pushed by left ventricle. Because remember, before this it was just pushing into whatever the empty space was, right? But the empty space here is less resistant than the systemic vascular resistance available, right? So that's why it's going to push into this area as well compared to this. So first it's going to push into this, and then it's going to push into the other side, I guess. You don't have to know all that. Just remember that there's electrical alterance. So what is electrical alterance? You see how the R wave here is over here on this line? It's on this line. So okay, on this line, right? But if you move over here, it's a little down. If you move here, it's a little up. If you move over here, it's down, right? So the change in R wave amplitude is what that means. Electrical electrons. So it shows low voltage QRS. Okay. Also, there's this, when I told you about the leads and how it does it. So you have V1 here, and the electrical impulse comes towards this lead, right? So when it comes towards the lead, it goes up, and when it goes away from this lead, it goes down. Okay. So it goes down from here, right there. Okay, and then again it's going from here to here, and then after it reaches here, then it disperses into other areas of the heart, and then it picks up over there. For if you're looking at V5 compared to V5, this is coming towards V5, so it's gonna have a positive wave, and then it's going away from V5 from like over here after it turns, right? After it turns in this direction, like this direction, it goes down. Okay, so that's how ECG works. So echocardiogram shows pericardial effusion. So pericardial effusion. We did that. Okay, diastolic artery collapse. So how would you treat this? You just put in a needle and suck up all that fluid. So pericardiocentesis, or you can do a surgical drainage. The buzzword here is pulsus paradoxus, but they don't say pulsus paradoxus, they describe this. So how will they describe it? That there is a decrease in amplitude of systolic BP by more than 10 mmHg during inspiration. So they'll say that, they might just say this outright, or they might say that during inspiration, the blood pressure is 130, and then during expiration the blood pressure is 115, right? So that's more than 10. That means there's pulsus paradoxus. Increase in venous return, this is because of increase in venous return during inspiration. Remember the diaphragm, it pushes into the diaphragm, it pushes outwards, creating negative pressure into the lungs, which causes increase in venous return because it's like a suction effect. So this causes increase in renal ventricular filling, which causes interventricular septum to bow towards left ventricle. This is due to decrease in pericardial compliance. Decrease in pericardial compliance, that just means this thing can go further this way, Make that red as well. Right, so it can go further this way. So when this thing pushes this way, or when it contracts, it's gonna also contract this way a little, right? Because the fluid here is busy going this way. So when it's going this way, there's less pressure on the pushing this way onto the interventricular septum, right? So I don't know why I'm going into this much detail. You don't need to know it, so I'll just move on. Interventricular septum bows towards left ventricle due to decrease in pericardial compliance. Decrease in left ventricle ejection volume, okay, and then that causes decrease in systolic blood pressure. It's seen in constrictive pericarditis. So this is important. If they tell you that there's pulsus paradoxus, it can happen, of course, in cardiac tamponade. However, it also happens in constrictive pericarditis, obstructive pulmonary disease like croup, obstructive sleep apnea, asthma, or COPD, right? Then you also cardiac tamponade that we just did. So PCO is like the word for it, but you can just remember it by itself. So pericarditis and obstructive pulmonary disease. So obstructive ones are the croup, OSA, asthma, and COPD. Okay. On to infective endocarditis. So this can be due to bacterial and non-bacterial causes. So we'll learn about that as well. Okay. Infection of the endocardial surface of the heart typically involves more than one heart valve caused by bacteria more than fungi. Okay, majority of the time. Forms in acute is classically S. aureus, high virulence, large destructive vegetations on previously normal valves, rapid onset. Normally, it's going to be due to a person who abuses drugs, so IVD, right, intravascular drug abuse. So you see that yellow pigmentation, that's the S. aureus. On the tricuspid valve, that's one cusp, that's second cusp, and that's the third cusp. And they split it in half, so that's 1, 2, and 3, 2, and 1. Okay, classically S. aureus, high virulence, large destructive vegetation on previously normal valves. Okay, so classically it's going to be that. If they don't give you any other cause other than they tell you that this person used to abuse drugs in back then, it's going to be S. aureus. Unless they tell you that this person went in to have dental procedure done, then it's going to be subacute, classically virulence streptococci, low virulence, smaller vegetations on congenitally abnormal or diseased valves, right? So remember, S. aureus produces dextrin, and the dextrin attaches to the aggregational aggregated platelets. Why do you have platelets there? It's because you will have platelets wherever you have damage, right? So if you have damage in the heart valves, right? So diseased heart valves, you'll have platelets there, and then virulence makes dextrins, so on itself. So dextrin then attaches to the aggregated platelets, and then now you have virulence on your heart valves. Okay, so smaller vegetations on congenitally abnormal or diseased valves. Sequelae of dental procedures, gradual onset. Presents with fever, most common, new murmurs, vascular and immunologic phenomena. Vascular phenomena, septic embolism, petachi, splinter hemorrhage. They'll give you one or two of these, right? They'll say that there's a linear line in the nails, and they tell you, it's endocarditis. That's like the number one thing. There was a story about this, manicurist or pedicurist, those people who do the nails for the guys. The pedicurist was doing like nails on this one woman, and she noticed this line, so she went home and looked it up on Google because she was concerned about the line. She had never seen it before. So she looked it up and she found out that it's because of infection in the heart. So like in the middle of the night, she calls up her client and tells her that this is what she found and she should get it checked. So she went to the hospital the next day, and lo and behold, she was suffering from an infective endocarditis, and it wasn't symptomatic yet. So she saved her life. Okay, back to this. Splinter hemorrhage, linear hemorrhagic lesions on nail bed. Genway lesions. These are painless, flat, erythematous lesions on palms and sole. Okay, why does this happen? It's because the vegetation, it goes through the circulation, and it causes microthrombitis. Okay, it's just thrombus, so it's obstructing the flow of blood. That's why you have these lesions on palms and soles. And obviously they're going to be tender. They're not tender. Sorry, my bad. They're painless. Okay, because why? Because usually they're going to have like collateral circulation, I guess. That's why it's not painful. Immunologic phenomena, Immune complex deposition, glomerulonephritis, Osler nodes, painful, raised, malicious lesions on the finger and toe pads, things like that. Rot spot, you should know what that is. Retinal hemorrhagic lesions with pale centers. However, they will give you this splinter hemorrhage. That's the buzzword for endocarditis. Okay, especially if they tell you that's because of drugs. Okay, because here, mitral valve most common, more than aortic valve, and tricuspid valve involvement is associated with injection drug use. Don't try drugs. Okay. Why tricuspid? Because that's the first valve that the bacteria comes across, right? Because it comes from SVC and IVC and then into the right atrium, and first valve it comes across is tricuspid valve, so it attaches there more commonly. Because once it goes into the lungs, yeah, it acts like a filter sort of thing, right? So common associations: prosthetic valves, so S. epidermidis. Remember that's novopiacin sensitive. GIGU procedures, enterococcus. Then you have, enterococcus. Then colon cancer, S. galacticus, formerly S. bovis. This is the one where if you find these in lungs, chances are you have colon cancer. Gram-negative HEC organism, that's Haemophilus aggregatibacter, formerly known as Actinobacillus. Cardiobacterium, Echinella and Kingella. Then you have culture negative Coxiella bartonella, that's cat scratch disease, and that's Q fever one, with amniotic fluid, animals amniotic fluid. Injection drug use. So with that, firstly, if they don't give you any other clues other than telling you that it's just this person used to abuse drugs, it's going to be a SARIUS. If they tell you that the culture makes bluish greenish pigmentation, it's going to be this. And if they tell you he has HIV, it's going to be this. Okay, or like oral thrush or something like that. I don't know. Not for endocarditis though. Endocarditis, it's usually something serious if you have fungal infection, right? Endothelial injury. So formation of vegetation consists of platelets, fibrin, and microbes on heart valve. Right. Valve regurgitation, septic embolism, systemic circulation in left-sided endocarditis, pulmonary in right-sided. Diagnosis requires multiple blood cultures and echocardiography. Okay. So then there's also non-bacterial thrombotic endocarditis, which is also called merantic endocarditis. Rare and non-infective vegetation typically arise on mitral or aortic valve and consists of sterile platelet-rich thrombi that dislodge easily, usually asymptomatic until embolism occurs. Okay. So again, vegetation typically arise on mitral or aortic valve for non-bacterial thrombotic endocarditis and consists of sterile platelet-rich thrombi. Okay, it's sterile because it doesn't have any bacteria in it, so there's no infection. Platelet-rich thrombi. This is the reason why that lodges in easily, right? So this is the reason why there's thrombus. Usually asymptomatic until embolism occurs. So you won't notice it until it lodges into like a small capillary somewhere and it causes, symptoms. Associated with hypercoagulable state. Hypercoagulable is just, you have a lot of clotting factors in your system, including platelets, which causes that. In advanced malignancies, so associated with hypercoagulable state and seen in advanced malignancy, especially pancreatic adenocarcinoma, okay, or SLE. This is also called Liebman-Sachs endocarditis. Remember this word because that's the one for non-bacterial. They'll give you a list of reasons of why there's endocarditis, and then what you get out of it is that there's no bacterial infection anywhere. Like the neutrophils is normal and eosinophils are normal and all that stuff. Um, so then in the option, you have to look for Libman Sachs endocarditis, right? Because that's the one that's non-bacterial thrombotic endocarditis. Okay, and it happens because of either thrombi, platelet-rich thrombi, or because of hypercoagulous malignancy, like pancreatic adenocarcinoma or SLE. Rheumatic fever, a consequence of pharyngeal infection with group A beta hemolytic streptococci. So beta hemolytic ones are the pyogens and agalacti, right? Late sequelae include rheumatic heart disease, which affects heart valves, right? So that's the pyogen one, right? Late sequelae including rheumatic heart disease, which affect heart valves, mitral more than aortic, more than tricuspid. High pressure valves affected the most. Okay. So yeah, that's the way to remember this. Rheumatic heart fever, right? Sorry, rheumatic fever. So early valvular regurgitation, late valvular stenosis. Okay, early valvular regurgitation. Okay, so initially you're gonna get regurgitation through these valves, and later you'll have stenosis. It's associated with Ashkoff bodies. These are granulomas with giant cells. You need to know what these look like. And it's basically these things over here. Blue arrow. Right. So right there. Right there. But more importantly, let's see what it looks like. Okay, that's a diagram. So that thing right there. It's hard to figure out in a photo. It's hard to figure out in the photo, but let's see. Okay, so like that. What's easier to figure out is like the Ashkoff body is gonna have these little cells. They're called actinoshav or anitoshav cells. I've never read this word out loud, so right now I realize I've been saying it wrong in my head. But Antishokov cells, right? So these are enlarged macrophages with ovoid, wavy, rod-like nucleus, right? I call it the caterpillar cell because it looks like caterpillar, and that's what they're called as well. Okay, so that wasn't special, but I'll show you what they look like. It's not anti, it's anit. Okay. So these things right here. Okay. Let me do it. Yeah, so see how it looks like a little caterpillar inside the cell? And those. And they're found in a larger giant cell, which is called the Ashkoff body. Okay, but if you start seeing these kind of cells, it's rheumatic fever. It looks like that thing, right? Cool. I think that justifies it. Okay, so it's associated with Ashkoff body, Ashkoff's bodies, granuloma with giant cell. And Anichakov cells, enlarged macrophages with ovoid, wavy, rod-like nucleus, red arrow in A. Right there. Increase in anti-streptolysin O or ASO, and there is increase in anti-DNase B titers, right? So if they tell you there's increase in ASO titer, that only happens because of S pyogenes, and it's because of rheumatic fever. But if they tell you that it's that anti-lysine streptolysin O is normal or negative, the titer, that means you shouldn't think of rheumatic fever or strep pyogenes. You should move on from that thought of process, right? Even though it seems like this would be the answer, don't pick it if they tell you this is negative or normal. They don't really give you titer for this though. Anti-DNase B titer. Immune, because that's non-specific basically. That's why. Immune-mediated type 2 hypersensitivity, not a direct effect of bacteria. Antibodies to M protein cross-react with self-antigens, often myosin, which is called molecular mimicry. Quickly, I went over this in micro as well. What happens is once your body develops antibodies to the M protein on the bacteria, the antibodies, after it clears off the infection, it goes looking for M protein everywhere in the body, right? So whatever resembles this, which are myosin, right? So in the heart valves, on the myosin and the heart valve is where they find that. So they resemble the structure for M protein. So that's why it's called molecular mimicry. So now the antibodies that were created to fight off M protein are going to attach to the myosin on the cardiac cells, and this will cause your rheumatic heart disease. Okay. Treatment prophylaxis is penicillin. So these are the symptoms that you come across. Migratory polyarthritis, that's joint. Remember, this is for this has pyogenes, but also there are septic arthritis and reactive arthritis, right? So you have to remember about that too. Septic arthritis is S. aureus and gonorrhea and streptococcus. Reactive arthritis is because of Campylobacter, E. coli, Salmonella, Chlamydia, Yersinia, Shigella. Right. There's also monoarthritis just happening at one place. That could be because of septic or septic arthritis, arthrosis, rheumatic disease like this one, and crystal arthropaths. Then there's migratory arthritis, right? So that's because of gonorrhea as well, but they'll give you that there's a diplococci seen on culture or like under microscope or something. But also this, and then there's also one that's migratory thrombophlebitis, I think, and that's due to malignancy or cancer. Okay, so joints, migratory polyarthritis, carditis, nodules in skin, erythema marginatum. This is the bullseye one that you see due to Lyme's, but right, so it looks like a bullseye like that. Okay, bullseye right there. Okay. Then you have Sydenham chorea. These are involuntary irregular movements of limbs and face. Okay, so if you have all of these things in a question stem, it's going to be rheumatic fever because of strep pyogenes and group A beta hemolytic. Right. Sorry, group A, yeah, they give you that. Okay, so that's going to be strep pyogenes. So if they remember, group B is the A-galacti one. Okay. Syphilitic heart disease. So tertiary syphilis disrupts the vasa vasorum. So the vessels that supply the big vessels like aorta. So vasa vasorum of the aorta with consequent atrophy of the vessel wall and dilation of aorta and valve ring. So this is what I was talking about when they deliver a baby and the umbilical cord is necrosed. It's what could be the cause of this. It's going to be treponema pallidum, right? Because that's the one that causes syphilis. So tertiary syphilis disrupts the vasa vasorum of the aorta with consequent atrophy of the vessel wall and dilation of the aorta and valve ring. May see calcification of aortic root, ascending aortic arch, and thoracic aorta. Leads to tree bark appearance of aorta. Let's see if there's a photo for that. They're not going to show you the photo for this instead, but that's what it looks like. Okay. Can result in aneurysm of ascending aorta or aortic arch, aortic insufficiency. Acute pericarditis. This is inflammation of the pericardium. Okay. This thing right here. So inflammation of the pericardium commonly presents with sharp pain. This is the one where I told you that the patient is trying to lean forward and it makes them feel better, right? So, and if you were listening to it, it's going to have a friction rub. You'll hear a friction rub. Okay. Inflammation of the pericardium commonly presents with sharp pain, aggravated by inspiration, and relieved by sitting up and leaning forward. Often complicated by pericardial effusion between yellow arrows in A. So this is the pericardial effusion. So this can happen because of this. Or wait, often complicated by pericardial effusion. Yeah, okay. Presents with friction rub. ECG changes include widespread diffuse ST segment elevation. Okay. Again, elevation happens because the signal had to travel all the way around. Okay, so now it's just, if it's going from here, point A to point B, now it has to travel along this one, right, instead of just going straight to this. Try to make sense of it like that. ST segment elevation and or PR depression. PR depression is the start of atrial depolarization to the start of ventricular depolarization. Okay, so depression in that area. Causes include surgery, cardiac causes. So surgery of heart, connective tissue disorder, cardiovascular events, for example, acute MI and Dressler syndrome. Autoimmune, for example, SLE and rheumatoid arthritis. Radiation, renal failure, uremia. Right. Idiopathic, most common, presumed viral. Infections, for example, Coxsackie B and neoplasms. Okay. So when they tell you that patient is sitting up and leaning forward, that means there's pericarditis. So then you have to figure out what's the reason for it. They might tell you that neutrophils are increased or lymphocytes are increased or something like that. You can figure it out from that. If they tell you the blood was normal, right, but there was increase in proteins, it could be autoimmune. If they tell you that there's some kind of malignancy, it's because of neoplasm. If there's increase in creatinine and everything else is normal, it's going to be because of this. Maybe increase in BUN as well. Not normal, but BUN and creatinine are increased. That's going to be this. For idiopathic, it could be, it's none of these basically. None of these, so it's going to be, the most common cause is idiopathic. Okay, so we just assume that it's viral. Treatment. Oh yeah, and cardiovascular event, so acute MI or Dressler. For Dressler, you will see, immunoglobulins near the heart, okay, because that's the complex, settles where this is, and then it's going to cause reaction, which is called the Dressler syndrome. This is different than the autoimmune causes, which is SLE and rheumatoid arthritis. Treatment is NSAIDs, colchicine, glucocorticoids, dialysis. NSAIDs because of leukotrienes, it decreases the inflammation as well. Colchicine because it reduces the, I guess, what does it reduce? Just the MOA of colchicine again. Isn't this okay? So action tubulin disruption. This leads to subsequent downregulation of multiple inflammatory pathway and modulation of innate immunity. Okay, so it's anti-inflammatory. That's why we give it in the cow. Glucocorticosteroids suppresses immunity again for this, right? And inflammation is anti-inflammatory. Dialysis because of uremia, so we gotta filter out the blood to get rid of the waste products. Myocarditis. Inflammation of the myocardium leads to global enlargement of heart and dilation of all chambers. Major cause of sudden cardiac death in adults less than 40 years old. Presentation is highly variable, can include dyspnea, chest pain, fever, arrhythmias, persistent tachycardia out of proportion to fever is characteristic. Multiple causes. So it could be basically anything and everything, right? They'll give you that it was gram positive or gram negative or DNA or RNA virus or something like that, right? So viral, for example, adenovirus, this is the DNA virus. Coxsackie, that's the hand, foot, mouth disease, right? Found in what class of RNA, if you can remember? Perch, I think. Parvovirus, B19, that's DNA virus. HIV, right, that's retro. And herpes, right, HHV6, that's Rosella one. Human herpes virus, so that's the Rosella one. Okay, the fever comes first and then it gets resolved and then you get the rash. Lymphocytic infiltrate with focal necrosis, highly indicative of viral myocarditis. Okay, if you have lymphocytic infiltrate with a focal necrosis, always think viral for myocarditis. Okay, again, lymphocytic infiltrates with focal necrosis is viral cause of myocarditis. Okay, parasitic threats, for example, Trypanosoma cruzi. Okay. That's the one that looks like the hat. And then you had Toxoplasma gondii from the cat. Contaminated and pregnant ladies should stay away from cat. You'll see ring formation and hydrocephalus in a baby, one of the torch syndromes. So you see hydrocephalus, if you remember the little Gandhi photo that I had. Calcification, the eye. Had lenses, so that's for retinal something. Ring lesions as well. Then sunspots were calcification, and the big head was hydrocephalus. Bacterial, Borrelia burgdorferi, that's the Lyme disease one. Mycoplasma pneumoniae, that's the walking pneumonia one. Corynebacterium diphtheria, that's the bullneck one. Also it looks like the safety pin or clubs. I forgot. It's one or the other. Actually, let's check it out so we don't forget it. Yeah, so it looks like clubs, dumbbells. Okay, dumbbell one. Toxins, for example, carbon monoxide and black widow venom. Okay, this is due to burning house furnace and all that stuff. heating, and all that stuff. What does it do? It causes leakage of protons, causing... No, not this one. What was this one? I'm losing my biochemistry. Okay, we'll just move on. Rheumatic fever, drugs, the doxorubicin and cocaine, they cause dilating myocarditis, myocardiopathy. Sorry, dilated myocardiopathy, cardiomyopathy. Sorry. Yeah. Autoimmune, for example, Kawasaki disease. That's the strawberry tongue one. Sarcoidosis causes vitamin D. It happens in middle-aged women usually, and predominantly it happens in like blacks. SLE, that's systemic lupus erythematosus, as well as polymyositis, and so this was butterfly rash, right? Or malar rash. For this, it's going to be weakness in the hips or shoulders kind of thing, and Croton nodules, or you'll see a shawl-like rash for poliomyositis or dermatitis. Also, you'll find anti-Joe and anti-Me Too for these. Okay. Complications include sudden death, arrhythmia, heart block, dilated cardiomyopathy, heart failure, mural thrombus, and systemic emboli. Mural thrombus is it affects all three layers with systemic emboli. Okay, got through that. Cardiac tumors. The most common cardiac tumor is a metastasis. For example, melanoma. Okay. So most of them are metastasized and come here and make it. The most important one is myxomas. Okay, remember I showed you the video for this. So it's the most common primary cardiac tumor in adults. Arrow in A. Okay, so that arrow right there. And it happens in left atrium all the time. It won't happen anywhere else. So if you see any kind of formation of a ball or something and it's moving, it's gonna be myxoma. But if it's not moving and it's somewhere attached to the anywhere else other than the valves, it's gonna be because of thrombus. Okay. So 90% occurs in atria, mostly left atrium. Myxomas are usually described as a ball valve, right? So obstruction in the left atrium. So what happens is when blood comes in and these valves open up, there's a forceful suction right into the left ventricle. So this ball is gonna go and attack and block that little opening, and that's why it causes obstruction in the left atrium, associated with multiple syncopal episodes, because then the blood is not reaching the brain, right, the head. Interleukin 6 production by the tumor. So it produces IL-6, that's the acute phase reactant, leads to constitutional symptoms. For example, fever and weight loss. Remember, that's the one that causes cachexia, are responsible for all that stuff, weakness, cachexia and all that. May auscultate early diastolic tumor plop sound. Mimics mitral stenosis. Murmur and symptoms worsen in upright position, improve when laying down. Histology is gelatinous, so this is important. Histology is gelatinous material, myxoma cells immersed in glycosaminoglycans, also known as GAGs. Okay. Adults make 6 mixed drinks, so remember that, and most importantly, remember the makeup of it. Gelatinous material, so immersed in glycosaminoglycans. Okay. And then you have rhabdomyomas, most frequent primary cardiac tumor in children. It's associated with tuberous sclerosis, type 1 and type 2, remember they have that. Histology, hematose growth, and most common in ventricles. Causal sign, paradoxal increase in okay, that's a cosmal sign, right? So just like the paradoxal pulse, you have to remember pulses, paradoxes. Just like that, you also got to remember cosmal. It's right next to it, so don't mix up the two, because on a test you might mix up the two. So this is paradoxal increase in JVP, okay, on inspiration. That one was increase in systolic blood pressure during inspiration. This one is increase in jugular venous pressure. Normally, inspiration causes negative intrathoracic pressure because of diaphragm pulling downwards and causing negative pressure in the lungs. So that those lungs are gonna create a suction in the right heart. Okay, so negative intrathoracic pressure, which will cause increase in venous return. There will be increased amount of blood coming into the right atrium. Okay, and this will cause decrease in jugular venous pressure. Now, if there's impaired right ventricular filling, you'll have right ventricle which cannot accommodate increase in venous return during inspiration, right? So then you'll have blood backing up into the vena cavas, and this is what's called the cosmal sign, right? May be seen with constrictive pericarditis, restrictive cardiomyopathy, and right heart failure, and massive pulmonary embolism, right atrial ventricular tumor as well. Okay. Just know what this is and where it happens. It does not happen in the left heart. Okay. It could be around the heart. It could be on the right side of the heart. It could be in the lungs, right atrial or ventricular tumors, but not the left side of the heart. Because why? Because left side doesn't affect the GVP, right? Hereditary hemorrhagic telangiectasia, also known as Oslo-Weber-Rendu syndrome. This is autosomal dominant disorder of blood vessels. I think this is the one where you have decrease in immunoglobulin A, G, and E, right? Because of the age that we talked about. Actually, let's go look at that real quick. Ataxia. Right there. So decrease in hemoglobin A, hemoglobin G, and hemoglobin E. Right. There is increase in EFP. Okay. Lymphocytic cellular atrophy and increase in risk of lymphoma. The way I told you guys to remember this is that this thing is it's on the skin and skin ages, right? So. And it happens because of exposure, ages because of exposure to rays. So it was X-rays exposure, right, which increases the sensitivity to radiation. Okay, back to 323. Okay. Hereditary hemorrhagic telangiectasia. So what is that? Findings are blanching lesions, telangiectasias on skin and mucous membrane, recurrent epitexis, AVMs, or also known as atriovenous malformations, for example in brain and lungs and liver, GI bleeding, and hematuria. Okay. Cardiovascular pharmacology. Okay. So now we're on pharmac section of the CVS. You have hypertension treatment. For primary hypertension, you just give whatever decreases the blood volume. Right. So you have thiazide. You have ACE inhibitors. You have angiotensin 2 receptor blockers. So those both are part of the RAS system. So it's blocking the RAS response. Then dihydropyridine, calcium channel blockers. You have hypertension with heart failure. Then you give diuretics, ACE inhibitors, ARBs, beta blocker compensated heart failure, and aldosterone antagonist. Okay. You give diuretics in this. You give diuretics in this, the thiazide one. Here you also give ACE inhibitor and ARBs. Here you give ACE inhibitor and ARBs. You give beta blockers in heart failure, but only for compensated heart failure, right? You can't give it in decompensated one. Why? Because it's not preserved ejection fraction. Right. So aldosterone, you also give aldosterone antagonist. That's also part of, I guess, this right here, because it does the same thing. Blocks the RAS response. So when you block the RAS response, what's going to happen in hypertension? So when you block the RAS response, what's going to happen in hypertension? You're going to get ANP and BNP, right? Atrial natriuretic peptide and brain natriuretic peptide. And what do they cause? They cause, they try to lower the blood volume, and they only get released when there's high blood volume going through the atria and ventricles. So now you're not going to get that aldosterone escape mechanism or response, right? Because you're blocking the aldosterone antagonists. Okay. Beta blockers must be used cautiously in decompensated heart failure and are contraindicated in cardiogenic shock. In heart failure, ARBs may be combined with the neprilyl inhibitor and sacubitril. Okay. Hypertension with diabetes mellitus, ACE inhibitors, ARBs, again, RAS system, calcium channel blockers, thiazide, diuretics, and beta blockers. Okay. This is just hypertension with diabetes. Nothing about the heart. So, ACE inhibitor and ARBs are protective against diabetic nephropathy. So remember that. These are your prills, and what was the other one? We'll look into it. Okay, so these are protective against diabetes, and normally people who have diabetes do suffer from hypertension. Why? It's because of the hypofiltration that happens, right? So it's going to cause that. It's going to cause renal artery to get arteriosclerosis around that as well. And beta blockers can mask hypoglycemia symptoms. Okay. What's hypoglycemia symptoms? That's when you're feeling dizzy and they seem like they're drunk, but they're going into hypoglycemic coma or whatever. Hypertension and asthma is you give ARBs, but you can't give ACE, right? Because of bradykinin inhibitor as well. That's because ACE breaks down bradykinin. So if you give ACE inhibitor, then there's going to be rampant action of bradykinin. Okay, so ARBs, calcium channel blocker, thiazide diuretics, and cardioselective beta blockers. Cardioselective ones are which ones? That's A2M, was it? I'm trying to remember. Yeah, A2M, I believe that's right. So all the lols that start, the first letter starts from A to M. Those are the cardioselective. Everything after M, so N to Z are both cardio and beta 2 selective. Avoid non-selective beta blockers to prevent, so that would be N to Z. Avoid non-selective beta blockers to prevent beta 2 receptor induced bronchoconstriction. Avoid ACE inhibitors to prevent confusion between drug or asthma related cough. Hypertension. So the cough is from the bradykinin. Sorry. Hypertension and pregnancy. Um, New moms love hugs. This is the way you should remember it because that helps. No, wait. New moms. There was another one actually, not this one. But anyways, now I just remember it. So nifedipine, methyl-dopa, labetalol, and hydralazine. They're all safe to be given for hypertension in pregnancy. Now, cardiovascular agents and molecular targets. So the calcium channel blockers. There's dihydropyridine over there. Okay. And there is ANP, BNP over here, and nicituride. Here we have nitrates. That's this whole mechanism here. We have GQ agonists, right? So that's, remember the diagram that we looked at. This diagram, right? Right. So GQIP3, which goes to sarcoplasmic reticulum, and then the calcium then goes on to activate MCL, or medium light chain kinase, right? Calmodulin complex, or it can come from here, L-type voltage gated channel, okay, and it does the same thing. When it activates MLC kinase, what happens? It phosphorylates the myosin P and causes contraction. Myosin and actin, so they need to be phosphorylated to cause contraction, right? So that when there's phosphatase available, then the P goes away and that causes relaxation. Okay, so let's go through this. Okay. Look at that while we read. So we have calcium channel blockers: amlodipine, clevidipine, nicardipine, nifedipine, nimodipine, right? Dihydropyridines act on vascular smooth muscle, and then you have non-dihydropyridine. These are diltiazem and verapamil. Okay, so they act on the heart. So the place where you might get confused is which one was acting on the heart and which one was acting on the system, right? So I guess you can remember it like non-die. So you would die if it was on the heart. So if you want to prevent dying, so non-die, it's going to be non-dihydropyridine on the heart. Okay, and these are your diltiazem and verapamil. Dil also means heart in Hindi, so I don't know for you non-Hindis if that would help, but yeah. And then you have verapamil. Okay, Vira means warrior as well. So warrior have like big hearts kind of thing. Just a way to remember that they're non-dihydropyridine and they act on heart. Okay, and all these other ones they act on smooth muscle, the dipines. So their mechanism is similar. So mechanism, they block voltage gated L-type calcium channel. So that thing right there, and smooth muscle, causing decrease in muscle contraction, right? That vascular smooth muscle. So amlodipine will have same effect on smooth muscle as nifedipine, but then also they both have greater effect than diltiazem and verapamil. That's why they're not given in smooth muscle for smooth muscles, right? Over here and hypertension. So vascular smooth muscle, okay. And then for heart, verapamil has a greater effect than diltiazem, which has a greater effect than amlodipine, which is similar to nifedipine on heart. Okay, so L-type voltage-gated calcium channels. Remember that. That's the important one. Okay, dipines act on that. Clinical use, dihydropyridine. So dihydropyridine is not the heart one. So except nimodipine. Nimodipine is the one that they use for SAW, I think. Was that given? Yeah, SAW. So the way I remember this, for you folks in India, Nimo is like Namo, right? And Narendra Modi, and he stays with Amit Shah for SAW, or subarachnoid hemorrhage. That's how I remember nimodipine for SAW. For other people, I don't know how you're gonna remember that, but remember that nimodipine is for SAW, and this is very important because they test you not only in this but also in neuro or CNS. Yeah. Okay. So dihydropyridine, except for nimodipine, it's used for hypertension, angina, including vasospastic type, Raynaud phenomena. Dihydropyridine mainly dilates arteries, okay, and it's given for hypertension and angina. You have nimodipine for subarachnoid hemorrhage. It prevents cerebral vasospasm. You have nicardipine or clevidipine. This is hypertensive, used for hypertensive urgency or emergency. So urgency is when there's no end organ damage, and emergency is when there's damage. Dihydropyridines, non-dihydropyridines, so these are your heart ones, is given for hypertension and angina and atrial fibrillation or flutter. The adverse effect is gingival hyperplasia. Dihydropyridine will cause peripheral edema, flushing, and dizziness. Non-dihydropyridine, cardiac depression, AV block, hyperprolactinemia, and verapamil, that's the important side effect, and constipation. Okay, hydralazine. Mechanism is it increases GMP, right? So CGMP would be right over there. Okay. So I don't see hydralazine anywhere, but it increases CGMP. Okay, so it increases CGMP, which leads to smooth muscle relaxation, right? So when you have this, it causes increase in MLC phosphatase activity. So myosin and actin will lose the P or phosphate group, which causes relaxation. Okay. Hydralazine vasodilates arterioles more than veins. Okay. Afterload reduction. There's reduction in afterload but no effect on the preload. Clinical use: severe hypertension, particularly acute, heart failure with organic nitrates, safe to use during pregnancy, frequently co-administered with beta blocker to prevent reflex tachycardia. Sorry. So basically, what would this do? So when you give a hydralazine, what's going to happen? There's going to be decrease in the vasoconstrictions, right? So decrease in afterload and all that stuff. But when you do vasodilation, what happens? Sorry, I think I said the wrong thing somewhere up here. So when you do vasodilation over here, there is decrease in venous return as well, because if there's pulling of blood in arterioles, there's not enough pressure for that to increase blood in veins either. So it's gonna have decrease in veins, which will decrease venous return. So that will decrease preload as well. Okay, so when you have decrease in preload, that will decrease the afterload as well, right? That's why there's afterload reduction. So when that happens, decrease in cardiac output again goes to the brain, signals the brain, and the brain sends sympathetic signals. So when you have sympathetic signals on the vessels, it's gonna try to cause vasoconstriction, but that's not gonna happen because there's high activity of MLC phosphatase, right? So even though there would be MLC kinase activity, this one's gonna overpower it. So there will be net vasodilation, and also it's gonna activate the beta receptors. So to prevent that, because that would cause the reflex tachycardia, you give beta blocker for that. Adverse effect: compensatory tachycardia, contraindicated in angina and coronary artery disease. We talked about that. Fluid retention, headache, angina, and drug-induced lupus. We talked about it in angina portion. Why you shouldn't give vasodilators, right? Because of the coronary steal syndrome. Then you have a hypertensive emergency. So treat with labetalol, clofidipine, phenylidipam, nicardipine, and nitroprusside. So nitroprusside is short-acting vasodilator. It has an equal artery and venous action. There's increase in cGMP again. It causes MLC phosphatase to activate via direct release of NO. Okay, so nitric oxide. Nitric oxide comes from L-arginine. Okay, that's important to know. So they'll be like, okay, which amino acid activity is increased if there's vasodilation. So that's going to be L-arginine, because vasodilation primarily happens because of three things, and one of them is nitric oxide. Nitric oxide synthase is activated by calcium, and calcium is activated by these things: acetylcholine, alpha agonists, alpha 2 agonists, right? Bradykinin and cytokines. Because remember, alpha 1 is the vasoconstrictor, not alpha 2. Then histamine and serotonin and shear stress. Okay, it can cause cyanide toxicity, releases cyanide. Phenylidopam. Phenylidopam or dopamine. There are dopamine D1. D1 was excitatory, right? But it decreases stuff. So dopamine D1 receptor agonist, coronary, peripheral, renal, and splenic vasodilation. Okay, so it activates the vasodilation kind of thing. Okay, decreases blood pressure and increases net uresis. Also used post-operatively as an antihypertensive. Can cause hypotension, tachycardia, flushing, headache, and nausea. Nitrates: nitroglycerine, isosorbide, dinitrate, and isosorbide mononitrate. They all have nitrate in them, and nitrate, you just think of nitric oxide, and what does nitric oxide do, right? Vasodilate. So vasodilate by increasing nitric oxide in vascular smooth muscles. So this leads to increase in cGMP and smooth muscle relaxation. This has more action on the veins than the arteries, and this will cause decrease in preload in the right atrium and right ventricle as well, right? Clinical use: angina, acute coronary syndrome, pulmonary edema. Remember, again, this is a vasodilator, so coronary steal syndrome will happen there. adverse effects, reflex tachycardia, because remember, uh, similar thing to up there, hydralazine. You'll have decrease in cardiac output, so that will cause the brain to think that no, we need to cause vasoconstriction and activate the beta 1 receptors on heart, so we can block that with beta blocker. Methemoglobinemia, hypertension, flushing, headache, Monday disease, and industrial nitric exposure. So what happened back in the day when this is why people hate Mondays, because throughout the week they have been exposed to nitrates, and they're used to vasodilation in their body. But when they go home during the weekend, the exposure is gone, right? So then the body recalibrates itself. So when they come back to work on Monday, they have vasodilation, which causes headache and all that stuff. So that's why they hate Monday disease, because the tolerance that they built up during the week is all gone by the weekend, in the weekend, or during the weekend. Okay, so Monday disease and industrial nitrate exposure, development of tolerance for the vasodilating action during the work week, and loss of tolerance over the weekend. So then they have tachycardia, dizziness, headache upon re-exposure. Tachycardia because of reflex tachycardia. Okay. And when you have increased tachycardia, already there is decrease in venous return, decrease in preload, and whatever blood was trying to come in, tachycardia, due to increase in heart rate, it's not going to fill up the whole chamber either. So there's even less blood going to the head, so that causes headache upon re-exposure. Contraindicated in right ventricular infarction, hypertrophic cardiomyopathy, and with concurrent PDE5 inhibitor use. Right, that's your Viagra one. So sildenafil. This is why you get those warnings on the news, or like ads, sorry, not news, but ads where they tell you that if you had erection for longer than 4 hours, you should go see a doctor. It's because of this. If it's given with heart medicine, which is usually nitric oxide. Okay. Because remember, what this does is it relaxes the vessels in the thing, in the penis, and that causes the erection, and that's what the function is for this. But and also this causes vasodilation as well, nitrates, right? So now there is no opposing action basically, and that's why what this can cause is not vasodilation, vasoconstriction. Okay, vasodilation, right? I'm just trying to figure this out in my head. So there's increased vasodilation in this, so there's going to be ischemia because of some reason. We'll come at it in repro, I guess. But basically, there are chances of ischemia, and you don't want to do that, so that's why you have to go get it trained, basically. Anti-anginal therapy goal is reduction of myocardial oxygen consumption, MVO2, by decreasing one or more of the determinant of MVO. Okay. So that's mean venous oxygen saturation or whatever. And diastolic volume, BP, heart rate, and contractility. Okay, so anti-anginal therapy components are end-diastolic volume. Nitrates will decrease it. Beta blocker will have absolutely no effect, or they will increase it. Okay, but if you give both of them, there will be no effect, or it will be decreased, because then you don't have reflex tachycardia. So then, wait, I'm reading this wrong. End-diastolic volume, okay, I'll just go read through it. End-diastolic volume, nitrates says decrease, beta blockers, no effect or increase, and both together it decreases the end-diastolic volume. Oh, right, yes, because it's anti-anginal, right? So we want to reduce what? We got to reduce the oxygen demand, right? So the goal of reduction of myocardial O2 consumption, that's what that is. Sorry. Well, I was zoned out during this. By decreasing one or more of the determinants of myocardial O2 consumption. End-diastolic volume, BP, heart rate, or contractility, all of these. Okay, so end-diastolic volume, you decrease it by decreasing the preload with nitrates. Beta blocker, no effect or increase in 1. Beta blocker does what? It blocks B1, which is known for increasing heart rate and contractility. So when you use both of that, it won't have any effect, or it can be decreased on end-diastolic volume. Then blood pressure, again, it decreases, decrease in systemic vascular resistance. Beta blocker will act on B2, which is the vasodilator as well, so decrease blood pressure. Beta contractility, nitrates will increase this because of reflex tachycardia, right? Why does that happen? Again, decrease in cardiac output will cause, why decrease in cardiac output? Because of the decreased preload. It will send signals to the brain, so brain comes back to give sympathetic response to the beta 1 receptors on the heart, right? And that will cause increase in heart rate and contractility. Sorry, that one. And beta blocker, we can block that, so decrease in beta 1. And then you have little or no effect on contractility if you give both of them. Heart rate increase, again, same logic there with nitrates, same logic there with that, and same logic here. It won't have any effect, or it can be decreased in heart rate. Ejection time, decrease with nitrates, increase in beta blockers. Okay. Nitrates, it's not going to affect whatever blood volume is coming in, it's going to be the same. It's not going to hurt the function of the heart rate, but here it hurts the function of the heart. So ejection time is going to be increased because now the heart rate is decreased and contractility is decreased. When you give both of them, there are no effect. Then you have myocardial oxygen consumption. With nitrates, it decreases because decreased preload again, right? So decreased stretch on the wall of the heart. With beta blockers, there's decrease in that as well, because decrease in contractility and heart rate, and then with both, it has a synergistic effect. Okay, so verapamil is similar to beta blockers in effect. Okay, we don't have it here. Pindolol, that's not cardioselective, right? Because that's N to Z. So pindolol and acebutolol, that's a cardioselective, are partial beta agonists. Okay, that should be used with caution in angina. Okay. We have like 1, 2, well, just 1.5 page to go. So let me just make another link, and acebutolol are partial beta agonists that should be used with caution in angina. Renalizine and sacubitril. So renalizine mechanism, it inhibits the late phase of inward sodium current, thereby reducing diastolic wall tension. Okay. Again, renalizine mechanism inhibits the late phase of inward sodium current, thereby reducing diastolic wall tension and oxygen consumption. It does not affect the heart rate or blood pressure. Clinical use is refractory angina, and adverse effect is constipation, dizziness, headache, and nausea. This affects the late phase of inward sodium current. It's talking about the funny funny channels, right? No, inward sodium current, thereby reducing diastolic wall tension. Yeah, it is talking about that. Okay, right. So it's talking about the funny channel in the pacemaker, I guess, because that way, because it takes time to regenerate the potential, uh, the diastolic wall tension will be reduced because of that, and oxygen consumption is reduced as well. Okay, sacubitril, that's mechanism, is a neprilysin inhibitor. So it prevents degradation of bradykinin, natriuretic peptides, angiotensin II, and substance P. Bradykinin in the lungs, natriuretic peptide in the heart, the angiotensin II, right? The RAS system, and substance P. They all this will cause increase in vasodilation and decrease in extracellular fluid volume. Clinical use is used in combination with valsartan, right? That's an ARB, to treat the heart failure, reduced ejection fraction, or the systolic dysfunctional heart failure. Adverse effects: hypertension, hyperkalemia, cough, dizziness, contraindicated with ACE inhibitors due to angioedema. Both drugs increase bradykinin. Now we have lipid lowering agent. Okay, so for this, you gotta remember that it prevents breakdown of bradykinin, natriuretic peptide, angiotensin, and substance P, because they'll test you on the mechanism of this and how it reduces or increases vasodilation, and when you would use it. This is an important drug. Lipid lowering agents. So HMG coenzyme reductase inhibitor, atorvastatin, and simvastatin. Okay, so first let's look at this diagram so you understand what we're talking about. So we have acetyl coenzyme A. This is formation of or synthesis of cholesterol. So acetyl coenzyme A, HMG coenzyme A with the HMG coenzyme reductase, which becomes mevalonate and then cholesterol. With LDL coming in from the LDL receptors, that also makes cholesterol. Okay, so then the cholesterol, also you have ApoE receptor with the chylomicron remnant coming in to make cholesterol, and you have HDL here acting on the cholesterol as well. The cholesterol then becomes VLDL, synthesizes VLDL, the liver, and that VLDL gets thrown out of the liver into the blood, and then the VLDL can have FFA released from it to become LDL again, which gets taken up again by the liver, or the FFA goes into the adipose tissue, and if there's lipolysis in the adipose tissue, then again there's free fatty acids in the blood, like that. The chylomicron separates three ways. One goes into the liver, the remnants, whatever's left over after the free fatty acid, and HDL. Okay, actually not HDL. It combines with HDL, the chylomicron, and then it travels everywhere, supplying its receptors. Okay, so that takes care of that, and then you have intestinal lumen. In the intestinal lumen, you have cholesterol, free fatty acid, and bile acids, and all three of these things will make you a chylomicron, and the chylomicron then goes through the lymphatics into the blood. Okay, so we're gonna attack some of these sites. To reduce cholesterol. So lipid lowering agents, let's put it down here. HMG coenzyme A reductase inhibitor. So that's atorvastatin and simvastatin. This is the first drug usually given to reduce lipids. Okay, these are your statins. So lovastatin, pravastatin, simvastatin, atorvastatin, and rosuvastatin. What do? They stop cholesterol. Okay, so S for stop. How do they stop it? HMG coenzyme A reductase. Okay. Remember, there's also HMG coenzyme A lyase and all that other stuff, synthase as well. This is reductase. It will decrease the LDL, right? Because if it doesn't make cholesterol, you won't have VLDL. You don't have VLDL, then you don't have LDL. Okay. It increases HDL, right? Because now HDL doesn't have to bother giving up its markers to cholesterol, so then it can give it up to other stuff as well. Triglyceride decreases. Mechanism: it inhibits the conversion of HMG coenzyme A to mevalonate, a cholesterol precursor, which decreases the intrahepatic cholesterol, increases LDL receptor recycling down here, and also increases LDL catabolism. It decreases in there's a decrease in mortality in patients with coronary artery disease. So this drug, the statin, decreases mortality in coronary artery disease. Okay. Adverse effects or problems: hepatotoxicity. This is the number one. And then there's this myopathy. Remember, myopathy, because it happens in two things. Okay. It happens in this and also gym fibrosol, right? So the fibrates, gym fibrosol or fibrates. Myopathy is the number one adverse effect for it. So they might tell you that, okay, so fibrates was given with something else, and it caused CK to rise in urine or something like that. So CK gets leaked out of muscles. So when you have myopathy, you'll have increase in CK. So you were given, with fibrates, you were given statins. Okay, so hepatotoxicity, increase in LFTs, myopathy, especially when used with fibrates or niacin. Remember that as well. Niacin is B3. Okay, bile acid resins, that's cholestyramine, cholestyramine, and cholestyramine. Okay, so bile acid is right here, and that gets inhibited. So when you don't have that, that's an interesting mechanism for that. So let's just go over it. Decrease in LDL. Okay, you don't have chylomicron, you won't have free fatty acids. Sorry, wait. How does that happen? LDL. So chylomicron. Okay, so chylomicron, no cholesterol, no VLDL, no LDL. Okay. So decrease in LDL will cause increase in HDL and increase in triglyceride as well because of bile acid. So the mechanism is that prevent intestinal reabsorption of bile acids. So liver must use cholesterol to make more bile acid, right? So that's how it happens. So when you see, cholestyramine or cholestyramine or cholestyramine, I think of this Indian dish called chole. It kind of like looks like chole. So they all increase, cholesterol or bile acid, I guess. I don't know, but I remember this because of chole now. So chole is just chickpeas, so it won't help you. So just figure that out. How you gonna, if you see this drug, you gotta remember that it's bile acid resin inhibitor. Okay. So adverse effect for this is GI upset, decrease in absorption of other drugs, and fat soluble vitamins. Okay. Then you have ezetimibe. That's also, it decreases LDL, obviously. So if there's decrease in LDL, you have HDL increase. Uh, Triglyceride, it has no effect, or it can decrease it. The mechanism is that. So where is this? That is right here. Reabsorption of cholesterol. Prevents cholesterol absorption at small intestine brush border. Okay. So if it doesn't take in cholesterol, you won't have cholesterol, and it'll have to be made from other stuff. Right? Then you have rare. Yeah. So adverse effect is rare increase in LFTs and diarrhea. Okay. Lipid lowering agents is fibrates. Again, gymfibrosol. Right. The way I remember is that as gem, but I read it like Jim. Right. Not Jim. It's Jim. Who's Jim? So it's Jim. Fee. Bro. Okay. So since there's gym, you go to gym to make up muscles. So that's how you remember that there's myopathy, muscle pain, or destruction of muscles kind of thing. So there's decrease in LDL, obviously. If there's decrease in LDL, you'll have increase in HDL. Okay, but the most important thing here is that you're burning triglycerides at the gym. Okay, that's the only one that has like severe decrease in triglyceride. Okay, so that's the main effect of this. How does it happen? Mechanism is that activates PPAR alpha, and it upregulates LPL, increase in triglyceride clearance as well. Activates PPAR alpha, which induces HDL synthesis as well. Okay. So party at the gym. Okay. Party at the gym, and bezafibrate and phenofibrate. Don't really have to remember that because this is the one that usually shows up. But if you see fibrate, just remember that gymfibrosol is also a fibrate, and then you can connect all of this with that. There's party at the gym, so it activates PPR alpha, upregulates LDL, increase in triglyceride clearance because you burn triglyceride at the gym. Okay, and it also induces HDL synthesis. You have muscle pain at the gym because you work out a lot. So myopathy, increase in risk with statins, cholesterol gallstones via inhibition of cholesterol 7 alpha hydroxylase. Okay, so that's the adverse effect of it. Niacin, you give niacin, it will decrease LDL. Wait, yeah, niacin. Right, niacin is B3. Why am I losing my head? Yeah, it is B. Okay. Which one is it? B3. Okay, thank God. Not losing my head. LDL, HDL, and decrease in triglycerides. So it inhibits lipolysis. Okay. Hormone sensitive lipase. Oh, this thing. Okay. In adipose tissue, reduces hepatic VLDL. Let me just go back to that real quick, if I can. So hormone sensitive lipase, so it prevents this. Okay. So it inhibits lipolysis, hormone sensitive lipase. It inhibits this thing in adipose tissue, because this is adipose tissue. Reduces hepatic VLDL synthesis. Okay. There's flushed face, prostaglandin mediated, decreased by NSAIDs or long-term use. So it will cause hyperglycemia and hyperuricemia. Okay. Okay, so those are the adverse effects. This one is not really tested, so that's why I didn't remember this. But what was tested for this back in chemistry was like they tell you that this person has ketones and he's going through DKA or something, so he has high ketones in the urine. But this person is still making glucose even though he's not been given any glucose. So how is that possible? It's because of glycerol kinase. That's how. Because glycerol kinase converts TGL to glycerol, and glycerol then causes gluconeogenesis in the liver. Okay. You have pesky K9 inhibitors. K9 again, those cutie dogs. But over here they're gonna bite and rip open the LDL receptors breakdown basically. So they won't let it break down basically. They protect the LDL receptors. Okay. So here there's decrease in LDL again. So that's over here. PESK9. We didn't look at niacin, sorry. So adipose lipolysis. So niacin, so it's going to prevent the lipolysis of FFA. Okay. Yeah. Okay. So for pesky canines is elirocumab or evolocumab. These obviously they sound nothing like dogs, but you can think of them like Pokemons. So Pokemon are pesky canine Pokemon. So it decreases LDL. They bite them and then they reduce it. So if you have decrease in LDL, you will have a rise in HDL, and then you'll have triglycerides decrease. Inactivation of LDL receptor degradation will cause increase in removal of LDL from bloodstreams. Myalgias, delirium, dementia are the adverse effects, and other neurocognitive defects. Okay. For this, you can imagine like the wires that which one was it? The one that's usually, oh yeah, it was a nematode, I think. So a nematode in the dog that enters the human body will cause myalgia, delirium, and dementia, and all these things and symptoms, right? So, or you can just not bother with the dog analogy at all, and just remember that this is where it affects this. And then there is inactivation of LDL receptor degradation, which causes increased removal of LDL bloodstream. And at the end you have fish oil and marine omega-3 fatty acids. They'll increase slightly in LDL. Okay. However, it causes increase in HDL as well, slightly, and it decreases triglyceride at high doses. It's believed to decrease FFA or free fatty acids. It's not in here. Yeah, it's not. So niacin affects here and here. Okay. So believed to decrease free fatty acids delivery to liver and decrease activity of triglyceride synthesizing enzymes. Nausea, fish-like taste. Okay. And we're done with lipids and hypertension drugs. And now we're on to arrhythmics. Wait, not yet. We have glycoside, cardiac glycoside. So digoxin. This is an important drug. The mechanism is direct inhibition of sodium potassium ATPase, indirect inhibition of sodium calcium exchanger. So it will increase intracellular calcium, which will cause positive inotropy, stimulates the vagus nerve, and decreases HR, right? So remember this thing? While I was explaining this and doing a horrible job at it, and I drew you a circle with like a little receptors, and then I told you that there's like a sarcoplasmic reticulum with more calcium in it. So calcium is going to come in, it comes in, attaches, and then it attaches to receptor on this, causing release of more calcium out of the sarcoplasmic reticulum. So that thing right here, it's showing here. So why do we inhibit sodium potassium ATPase? So you have sodium calcium exchanger right here, and sodium potassium ATP is over here. So digoxin comes in, it inhibits this, it inhibits that. Potassium doesn't come in and sodium doesn't go out, right? So when you have enough sodium here, you're not gonna have sodium coming in from the sodium calcium exchanger, right? So if sodium doesn't come in, calcium inside stays inside, and this calcium is then going to attach to this receptor right here, this calcium here, and then this calcium here. So this calcium attaches to this receptor, and this calcium then gets released outside, right? Similar to this. So then you have increase in intracellular calcium, and the calcium then increase in TNC calcium binding, which causes an increase in cardiac contraction. Not sure what that is, but end result is that there is increase in cardiac contraction because of the whole myosin actin, phosphorylation and all that stuff. So clinical use is heart failure, increase in, because it increases contractility, atrial fibrillation, decrease in conduction at AV node, and depression of SA node. Adverse effects, cholinergic effects, nausea, vomiting, diarrhea, blurry yellow vision or when glow, arrhythmias, and AV block. This is an important one. Blurry yellow vision, remember that, because that's unique to this digoxin. All of this you will find in like a majority of all the drugs, one of these at least, right? So arrhythmias and AV blocks can lead to hyperkalemia, which indicates poor prognosis. Okay, why hyperkalemia? Because it's staying outside now, right, in the extracellular fluid, which indicates poor prognosis. Factors predisposing to toxicity: renal failure, decrease in excretion, hypokalemia, permissive for digoxin binding at potassium binding site at sodium potassium ATPase, drugs that displace digoxin from tissue binding sites and decrease in clearance, for example, verapamil, amiodarone, and quinidine. Antidote is slowly normalize the potassium and cardiac pacers, also anti-digoxin Feb fragments, so that's just anti-monoclonal antibodies against the digoxin molecules, and then also Mg, because you'll have electrolyte imbalance as well, magnesium. Okay, now we're on to antiarrhythmics, and for this I'm going to tell you to watch Dirty Medicine. That's, you go to, Dirty Medicine, antiarrhythmics. So this one right here, he does a very good job at explaining this, and I won't be able to justify it. So, and this is how I remember those drugs. So watch that video. It's sent on the group as well. So yeah, that's it.